Hello, everybody, and welcome to this podcast that also doubles as a public service announcement specifically for those living with asthma or even loved ones in your circle that might be asthmatics. Today, we talk to Professor Guy Richards, who is the Emeritus Professor of Critical Care and Pulmonology at the University of Witwatersrand and Charlotte Maxeke Johannesburg Academic Hospital. Today, he joins us to talk a little bit more about the latest type of global tests that reveal asthma treatment actually needs serious re-examining, specifically when it comes to people that are using a SABA blue reliever inhaler as the preferred, relief type of therapy. Professor Richards, let's start with a question about what's the latest in asthma management when it comes to the SABA blue reliever inhaler?
Well, asthma management has been relatively constant for a long time now, but a couple of new developments have occurred. And these relate primarily to patients with milder disease, patients who previously only took short-acting beta agonists.
So what does this actually mean for those who are living with asthma?
Well, if you do have asthma, that regular therapy with inhaled corticosteroids is actually mandatory. And if you don't take the inhaled corticosteroid, you will end up using far too much of the short-acting beta agonist, and you don't treat the underlying inflammatory component of asthma, which is the most important part of therapy.
All right. Professor, why do you think patients end up being over-reliant?
Well, a short-acting beta agonist or a SABA gives you immediate relief. It actually makes you feel as if something has happened and that the therapy that you are taking is working. The issue, though, is that all it does is it opens up the airway and doesn't treat the underlying inflammatory component. And remember that the inflammation is what causes airway hyperreactivity.
And how does one know if a patient is actually over-reliant?
In fact, most patients should not require to take their beta stimulant on a regular basis at all. So if in fact they're using them on a regular basis or having to use them on a regular basis, this indicates that there is airway inflammation which is inadequately controlled currently.
Whoa. Does this mean your SABA blue reliever inhaler is actually putting you at risk?
Well, the SABA inhaler may not itself be putting you at risk, in that it's not causing it directly harm, but it may well be a marker that you do have significant inflammation. And you may feel falsely reassured when you take your short-acting beta agonist that all is well, because you do get a response and you feel better after having taken it. But meantime, you still have the underlying inflammation, which is what is the component of asthma that will predict whether you are going to have worse exacerbations in the future.
Professor, do you have any messages for asthmatics out there and our listeners?
Well, the most important thing is to be sure that you are on appropriate therapy. If you take only the short-acting beta agonist, you don't have any anti-inflammatory component. And that's why they are potentially dangerous, because you're not treating the underlying cause of the asthma itself.
Now, can you talk to us a little about being over-reliant on your blue reliever inhaler? And most importantly, what are some of the signs of poor asthma control?
Okay, so asthma control is actually measured or monitored by 5 simple questions. And that really is, how do you rate your asthma control? How much has your asthma actually interfered with your activities of daily living? How often are you woken up at nighttime by your asthma? And how often are you utilizing a short-acting beta agonist? Now, the use of a short-acting beta agonist on a regular basis indicates that you still have underlying inflammatory disease. So over-reliance would indicate that you are using it more and more frequently in order to control the symptoms. And that shouldn't be necessary in patients who have asthma.
Is there a way that folks can know for sure that they are in fact over-reliant?
Well, there is a website, and it's found at rateyourreliance.com, on which the reliever reliance test is actually available. And using that and answering 5 simple questions, you can rate your status with regard to your reliance on a short-acting beta agonist. And you will get an idea then if, in fact, you are over-reliant on your short-acting beta agonist.
Right. So I've taken this test, and it suggests I'm one of those that are over-reliant. What do I do, Professor?
Well, the first thing you should do is visit your doctor and discuss this problem with your doctor. What your general practitioner or your physician will say to you is, we need to control your asthma better. We need to actually control the inflammatory component, and we need to use more of the controller rather than just the reliever, because that can be dangerous if you're using only the reliever.
Should patients be in a state of panic if they are over-reliant? And, should they maybe completely stop their asthma medication?
No, definitely not. It's critical that you continue to take that medicine which keeps the chest open in the meantime. The important point is, though, that you must, as soon as possible, get to a doctor to get your therapy optimized to also contain an inhaled corticosteroid, which will decrease the need for the short-acting beta agonist. But if the only thing that currently is keeping your chest open is a short-acting beta agonist, you must continue it until such time as you get to your general practitioner.
Wow. How regularly should an asthmatic visit their healthcare practitioner to check up, basically?
Well, that's a difficult one to say precisely. If you are well controlled and have no symptoms whatsoever, then a visit once every 6 months to 1 year is adequate. If in fact you are not well controlled and you are still utilizing your short-acting beta agonist on a regular basis, then you need to visit more frequently until such time as you are asymptomatic or minimally symptomatic. In other words, you are no longer waking up at nighttime, you're not using your short-acting beta agonist, you're able to do all your activities, etc., and you feel that you are well controlled as well. Then at that point, you can increase the duration between doctor visits.
Professor, here's a serious question. How prevalent is asthma in South Africa, right here at home?
It's extremely prevalent. We don't have accurate figures, but we believe certainly in terms of school-going children that it actually is in the region of 25 to 30% of school-going children.
Oh, these are very, very, very hard numbers to swallow. It's actually quite scary. And in conclusion, can asthma ever be controlled?
Well, the bottom line is that you first of all assess whether your asthma is controlled or not. And that goes back to those questions that I mentioned earlier. Some patients might only require the inhaled corticosteroid. If you are relying only on the opening medicine or the reliever medication, then you do not have well-controlled asthma and you are at risk of an exacerbation which might put you into hospital or even might result in death.
Oh, thank you so much, Professor Richards. That's both fascinating and frightening. And I think we want our listeners out there to remember asthma is highly treatable as a disease. In fact, asthma treatments are so effective that people have near complete control of their symptoms. Testing your over-reliance is important. It's actually key in controlling your illness. You can take the reliever reliance test right now. Just simply visit www.yes2breathe.co.za or www.rateyourreliance.com. You can follow our social media pages also at Yes2Breathe on Facebook and Instagram and our hashtag Yes2Breathe for daily updates and information. This podcast, guys, was proudly brought to you by AstraZeneca Africa and endorsed by the National Asthma Education Program, the Independent Community Pharmacy Association, and also the Pan-African Thoracic Society. Professor, I can't tell you how much your time that you've taken out to speak to us is appreciated. Thanks again for being in our company, and we really hope that this vital information can help. Take care and stay safe. Till next time. After being awarded his medical degree in 1978, Professor Richards specialized in internal medicine and subsequently qualified as a pulmonologist and intensivist. He was awarded his PhD in medicine in 1992 from the University of Witwatersrand. Professor Richards has twice been the co-chairman of the South African National Critical Care and Thoracic Society Congress and was chairman again in 2015. He has been awarded Best Research Paper, Best Presentation, and Best Publication on a number of occasions at Congress of the SA Thoracic Society and SA Critical Care Society of Southern Africa, most recently in 2019.